Hello and welcome to Spinal Chat episode 6. My name is Dr. Ivan Stoyev and I'm a board-certified neurosurgeon working in Nashville, Tennessee. Today's topic will be different approaches to the lumbar spine and different types of fusion procedures that we can do on the lumbar spine. Now, in the previous episode, I talked about lumbar stenosis and some of the surgeries that we do to fix that. Today, we're going to focus just on the surgical techniques and the different approaches that we have available for us. I'm going to start off with a traditional approach that we've had for many years. And this is to go from the back. We basically make an incision in the middle of the spine. We go down, and by doing this approach from the back, we avoid a lot of the vital organs and a lot of the important things that are out here in the front. So the only thing we have to really contest with is the muscles in the back. Now, you do have these large muscles running along either side of the spine. Now, these muscles are postural muscles. They're very strong and they maintain your body in an upright position. So when you walk and when you sit, you're using them to keep your position upright. We have to basically retract those muscles off to the side with special retractors so that we can gain access to the actual spinal canal here in the back. Now that causes pain because muscles don't like to be manipulated and retracted, and they get bruised up and they get banged up a little bit, and over the course of the surgery having these retractors pull them off to the side is not very nice. So this is where the majority of the post-operative pain comes from. It's really the retraction of these muscles. That also weakens the muscles and can cause some problems in the long term. So not ideal, but the advantage of this surgery is that there's nothing else really important here that can get hurt. So it's a fairly safe procedure to do. Now we can also put screws and rods and stuff like that, and we're going to talk about that in a few minutes. But this is the traditional approach. Now we also have minimally invasive approaches, which I specialize in, and this is kind of my passion because with a minimally invasive approach, you're sparing some of these muscles. You don't have to retract them. You don't have to injure them or cut them. You basically split the muscle fibers and you do the surgery through a little tube and a microscope. So the reason we can really do this very well is because in the lumbar spine, the spinal canal is filled with nerves that are basically floating in fluid. The spinal cord ends about right here between the first and the second vertebra. So there is no spinal cord, which means we can retract the nerves, sweep them out of the way, and have a lot of access in a large working corridor. We can get to many different points in the spine through one approach. So that allows this anatomy difference between the lumbar and the cervical spine allows us to be a little more aggressive and do a lot more things with small incisions here in the back. So the advantages again are that it's very safe. There's few things that can be injured in the process. But the disadvantages are that there is more pain because of these muscles that get really kind of sore and banged up and bruised up from this retraction process. We can approach the spine from the front, and that's going through the belly. And in the process of doing that, we have to basically sweep away the organs, the internal organs, off to one side so that we can have access to the spine. Now, most of us would use another kind of surgeon that works on the belly to get us to the spine because, we are spine surgeons, we're not belly surgeons. Usually it takes a vascular surgeon to perform that access and that approach for us. And they basically get everything out of the way so we can work on the spine. And from the front, we can remove discs that are diseased. We can put little plates and screws and decompress the spine and all this stuff. The advantage of this approach is that we're going through very little muscle. It's just really in the abdominal wall. And this is not as big and thick muscle as the ones that you have in the back, which means less pain. That means faster recovery, shorter hospital stay, and overall, much less pain after the surgery. There is a big difference between going in the front and the back as far as the amount of pain that the patient experiences afterwards. The disadvantage is that we have to really deal with a lot of abdominal organs in a way, and there is a possibility or the chance of injury to them because we have to work around them and kind of get them out of the way. There's also some major blood vessels that run along the spine here in the front, and we have to sometimes retract them and move them out of the way to do the surgery, and in some levels it's more difficult than others. The other disadvantage is applying in particular to young males who are planning on fathering children. There's a phenomenon called retrograde ejaculation that can occur after the surgery, and this is basically where males cannot ejaculate. The sperm actually goes in the wrong direction into the bladder instead of coming out, and makes it very difficult to get a woman pregnant that way. So for patients who are trying to have children and they're young, this is not a really good approach. It doesn't really affect the impotence or anything like that. It's just really the ability to ejaculate, and that can be disturbing for some males. Now, the chance of that happening is very small. I think it's on the order of 5 to 6%, but I don't offer this surgery to patients who are young males who are planning on having a family. We have also surgeries that we can do from the side of the spine, where the patient is lying on their side, and we make an incision on the side, and we approach the spine in this direction. The advantage of that, again, is that we're not going through a lot of muscle, so there's little pain associated with it and really quite quick recovery. The disadvantage is that, there is a large muscle that runs along the side of the spine over here called the iliopsoas muscle. This is the muscle that flexes the hip. So we have to go through that muscle in order to get to the disc space. And the muscle can get pretty sore and beat up in the process, just like the ones here in the back. So some patients may have a transient or temporary loss of strength in the flexion of the hip after the surgery. Another important thing here to consider is that these little nerves that are exiting through the foramina here between the vertebrae, they kind of join together into a network of nerves called the lumbar plexus. Now, these nerves control the sensation and the movement of your lower extremities. So they're running along inside that muscle and some on the top, and they kind of go in this direction. So as we're going through the muscle, we can actually see those nerves. So they are at risk, especially when we're retracting in that area. Now, we do have some monitoring devices that will tell us if we're close to the nerves, so we can pick a different spot of entering the disc. But nevertheless, there is small risk associated with this procedure. Now, again, these are very small numbers that we're talking about, so it's a very safe procedure, and it's very easy to do. And when I do this procedure, I don't actually require another surgeon to get me to the front, because the organs are already out of the way. I don't have to worry about them. So I do this myself without the help of another surgeon. So the advantages of this surgery, and this surgery is called XLIF procedure, extreme lateral intrabody fusion, or lateral fusion procedure. The advantages are very little pain. You're going through just a little bit of muscle to get there. The incisions are usually pretty small. This is considered minimally invasive. And patients recover very quickly from that. The disadvantages are, well, you have to go through this iliopsoas muscle. You have to worry about the lumbar plexus that is in this area. And you can't really do this surgery on the very last level very well. The reason for that is you have the pelvic bones that are kind of in the way, so you can't really get to that angle. Now, there are companies who have come up with these angled instruments that still allow us to do that, and I've done this surgery on this level too, but it was very difficult and time-consuming, and at the end, there are better ways of getting there than trying to struggle to go from the side. This iliopsoas muscle is really more concerning this lower portion of the lumbar spine. As you get to L1 and 2 and 2-3, there's very little muscle there, so there's very little risk for the weakness in the leg and also injuring the lumbar plexus, because there are only a couple of nerves here versus all these nerves coming together here into this network. So these are the advantages and disadvantages of this procedure. Now, there is another procedure called an OLIF, which is oblique lateral intrabody fusion, or oblique lumbar intrabody fusion, I'm sorry. And this is where we go at an oblique angle to the spine at about sort of this approach right here. That allows us to avoid the iliopsoas muscle because we're in front of it, and avoid also the vessels that are here in the very front. So we have a little window here on the side that we can go to and do the procedure. And it's basically a combination of the two procedures, the anterior and the lateral. So it's kind of halfway in between. So I still need to use a surgeon to get me there because we're a little too close to the organs here in the front. But I don't have to worry about the muscle here and the nerves. So that's an advantage of it. And there are some limitations to the different levels as where you go because of blood vessels and such, especially here in the lower part, it's a little more difficult to do. So here is a model of what a posterior lumbar intrabody fusion surgery looks like. This is again done from the back. And as you can see here, there are two little spacers or grafts that are placed in the disc space. So here's the disc space in the front, and you have these little grafts that go in. Now they do go in small like that, and then they expand like a little car jack. So that allows us to give some curvature to the spine and also support the weight of the spine here. Now, the surgery is done through an opening in the back where we remove these bones here so we can access the disc space in the back. We take the disc material out completely, and then we put one of these grafts on either side. So there's two of them. You can see it here from the top, how they are sitting here in the disc space down here. Now that gives us the anatomical alignment and support of the spine, but then we also have to put some screws and rods. So these screws go at an angle inward like that. These are called pedicle screws, and we put them like here and here, and some also on the bottom, and they're connected with rods. And then we secure the rods with a couple of little screws. So this is what a posterior lumbar intrabody fusion looks like. That allows us to decompress the spinal canal by removing these bones here, by removing the joints on both sides, so that area where the nerves are coming out is completely decompressed, and that occurs here on both sides. So it gives us a very comprehensive decompression of the spinal cord. Now, a variation of that is this posterior lumbar intrabody fusion surgery. Again, we have grafts that go in the disc space. These ones are not expandable. They're not like little car jacks. They're fixed in shape and size. So we put them in the way they are. Again, two of them, one on each side. We remove the joints. We remove the bones in the back. These screws, however, you see, are going a little bit out instead of going in. These are cortical screws. And the advantage of that is that you see how they're sitting closer together to each other. That allows us to make a smaller incision so that we can place the screws and take the disc out and do all the things that we did with the previous surgery, but with a much smaller incision. This is called a minimal access posterior lumbar intrabody fusion procedure. Another type of procedure is this model here describing, and this is done one of two ways. Either from the side of the spine, just like we discussed before, we could come from the side of the spine, remove the disc, and put this long graft in here. This is just to give support and alignment here for the spine. And the good thing about this is it's a very large graft, and it's got a large window inside. You can see there are two kind of windows that we pack with bone. So the more bone that you can have in that area, the better the fusion rate. So this allows us for a pretty good, successful fusion to occur. And it's kind of a single spacer here that goes in. Once we do this from the side, then we turn the patient over, and we can put these screws here in the back with little stab incisions in the back. We don't have to make a big incision, just a little cut, just enough to put the screws and the rods. So this is kind of a bit of a minimally invasive approach as well. So we end up having screws and rods in the back. These are pedicle screws, by the way, just because of the angle of which they take. And we can't really decompress anything in the back because we're not really opening this back area. We're just basically putting the screws. That's all we're doing in the back. All the decompression occurs here from the side, from this approach here. Now we can put the spacer also directly from the front by making an incision in the front, putting it in, doing a decompression that way, and then flipping the patient over and putting those screws in through little tiny incisions, just enough to get us to be able to put the rods and secure everything in place. So for the oblique lumbar interbody fusion procedure, this is a very similar technique where we kind of come at an oblique angle, but it's the same exact thing. We put this spacer in, and then we turn the patient over, and we'll put the screws, what's called percutaneously placed, meaning that we're making just a little stab incision to put them in and secure them with these rods and little set screws. So these are the basic ways of fusing the lumbar spine. And there are some variations of the above procedures, but this is kind of the standard overall review of lumbar spine fusions. Thank you very much for joining me today and spending your time with me. I appreciate all the comments, all the questions, all the subscribers that are following me, and stay tuned for future videos. If you have any suggestions, please contact me below and let me know if there is a topic or a theme or a particular surgery that you would like for me to discuss. Thank you very much.